the next speaker on the podium is an absolute superstar, Dr. ADIT GUPTA, and he trained at LV Prasad Eye Institute and then trained with Dr. Goldberg at UCLA. And ADIT, I don't think requires any introduction. He'll be talking about the botulinum toxin injections. If you like what we are doing and want to do more of it, you should be attending the midterm OPAI, which is occurring in Aurangabad. And Dr. Shubha, who's the organizing secretary, is there on the second last row. And we promise you there'll be more and more exciting stuff. Dr. Pallavi is there as well. They've got a stall near Allergan at P1. And please go ahead and register. There is an early bird prize as well. And she'll give you a 5-star if you register today itself. Thank you so much.
Very good evening to everyone. I thank Debraj for arranging this wonderful course year after year, and it's been always well attended, and we intend to propagate knowledge because this is one of the subspecialties of ophthalmology which is actually budding, and I promise you in the next 20 years, like in the US, it would be one of the most sought after. In the US, actually, ophthalmic plastic surgery is the specialty which matches even before cornea and cataract refractive. And I think India is going in the same way. To cut things short, I am going to focus on botulinum toxin for periocular rejuvenation. Dr. Shilpa has already made my job very easy by explaining the anatomy of the muscles. And obviously, we need to keep something for the course which has to be attended by you, which Dr. Debraj is talking about. So a lot of other indications are also covered in the course, which requires more attention to detail. These talks are going to be available on YouTube, going to be produced by AIOS. So I request you to not take photographs here. Before we injecting Botox is not very difficult. The most important part of a cosmetic practice is understanding what the patient needs. So evaluation and counseling of the patient, if it is done properly, completes 80% of the job. And actually 20% of the job is just injecting, which can be done by any trained doctor. So in evaluation of the patient, you have to understand the actual goals of the patient. Every patient is going to have different goals. It's not a copy, cut, paste thing. You have to understand a patient would want to look in a particular way, and you have to deliver on those goals. And obviously you have to cut out the red flags as well. So if there's a very manipulative, hostile patient, you would rather have them get injection done by one of your closest competitor. So you want to get these patients out or weed them out of your practice and not have them because they can be real troublemakers later on. Evaluation should be holistic. It should cover everything right from skin quality to deflation, inflation, volumization of the tissue, and not only wrinkles. Okay, so this is going to be covered by Dr. Debraj in much detail in his talk, how multimodal application of different specialities and different experts works best for patients. But what I'm going to talk about, since I've been given to talk about Botox, is the anatomy of a wrinkle. So whenever we think about a wrinkle, we just jump on that, oh, we are going to give Botox and the job is going to be done. But a wrinkle, the wrinkle is a composite of 4 parts. It's the epidermis, the dermis, the subcutaneous tissue, and the muscle. And what we are dealing with Botox is only the muscle part of it. So if a person has static wrinkle, it could be because of these 3 issues. And if you give Botox for these issues, sometimes it might not make the patient happy. So you should know exactly what component of a wrinkle you're treating. With Botox, we are treating the dynamic component, that is, we are working on the muscles. You might have to do adjunctive therapies depending on the anatomy of each patient. To convince patients to get injections done by you, you have to change the way you speak to the patients. So if you tell the patient that I'm going to paralyze your muscle, sometimes these patients are very sensitive. So if you, instead of using the word paralysis, if you just say I'm going to just soften your muscles or weaken your muscles a little bit to make it look more attractive, that could convince the patient in a better way. You never say that we are going to have pain during the injection. You use the word like you're going to have minimal discomfort, which will be bearable. So again, this is a win-win point. And we are going to soften your expressions rather than given a frozen look. So you have to obviously choose your words with caution while dealing with such patients. The anatomy of the muscle has been spoken about in detail, but before going or jumping to the injection part, a thorough assessment of the patient's expressions has to be conducted. You might choose to record or take pictures of this, because it helps you in learning, as well as it helps you in planning or formulating the plan while the patient is sitting with the numbing cream. So you ask the patient to do specific emotions. So if you're asking the patient, you're going to inject for the forehead, you ask the patient to raise the eyebrows, look at static and dynamic position, look at static and dynamic right EDs. Ask the patient to frown to assess the eyebrow muscles. So in this, we are assessing the forehead. I'm sorry that the video is cut on the top, but I'm also showing for the ease of the patients how we mark before. So we mark, you can show those specific points in the mirror to the patient and then formulate a plan along with them. So in this, we are formulating a plan for this patient for the upper face region and the lateral crow's feet. So these are the markings which are done. These are different in each patient. For crow's feet, you have to tell them to smile as broad as they can, and you can see you mark the area till where you feel them. So they are different in every patient. Sometimes they might extend right up to the hairlock. Sometimes they end abruptly just beyond the orbital rim. So the dosage has to be calculated accordingly. In a male patient, obviously, you might see that the muscular contraction and the brow muscles are stronger than a female patient. So again, in a male patient, the assessment is different. You have to perform your assessment and increase the dose by almost 10 to 20% than that of a female patient. Once the assessment is done, you may apply a mixture of prilocaine and lidocaine, which is called as a surface anesthetic or EMLA cream. This cream should be kept at least for 25 to 40 minutes, depending on what cream you are using. Some of the US formulations also have phenylephrine in them to cause vasoconstriction. It helps in patients who are going to get fillers. And this cream should be placed. There is also an occlusive tape which is available in these boxes. If you use the occlusive tape on the Prilox cream, it helps in the spread of the cream within the epidermis and dermis, and the action of the cream comes faster and the patients report lesser pain while injection. As my partner always says, that it's not the needle prick but the speed of injection that determines the amount of pain. So if you're gentle and slow while injecting, the pain or the discomfort felt by the patient is minimal. Now there are multiple muscles in the face. There are different muscles in the upper face, mid face and lower face, and as a beginner, you should always start injecting the upper face, especially the crow's feet area, because that is one of the easiest areas to begin with, and the margin of error is relatively higher as compared to the lower face muscles. In the lower face, you cannot afford to goof up because you can cause asymmetric smile very easily because the muscles are packed very closely to each other. But you need to know the anatomy of all these muscles before injecting. There are multiple types of botulinum toxin available in the market. Till now, Allergan was the only one available, but once their patent, this thing has expired, a lot of products from India as well as Korea have come up. You may try to use them depending on your comfort. Dilution, everyone knows, usually normal saline is used, and for cosmetic Botox, we prefer a concentration of 0.4 units per 0.1 ml, and it should be stored in the lower compartment of the refrigerator, not in the freezer. And some people say that we can use it even up to 6 weeks. So if your need for Botox is less, I have myself used it for a period of 6 weeks to 2 months without losing much efficacy for the molecule. This record is provided by the company which you buy the botulinum toxin from. This is very helpful because you can keep a chart of the patient and maintain records. You can transfer it to your EMR if you have an EMR. And it helps because you can titrate the dosage accordingly. The Botox need can increase year by year because of drug resistance, or sometimes you might overdose a patient and want to correct it at the next visit. So this is a very good way to maintain records and also show the patient that you are caring about them. Botox is although it's a minor procedure, it's not a minor procedure otherwise. So a consent is mandatory. You should always take a consent from the patient for any procedure that you do in your clinic. Now, let us come to specific indications around the periocular area. We'll first go step by step. Let's look at the crow's feet. So, if you look at crow's feet, you see that there are different anatomies of the crow's feet, but exactly for crow's feet, you are injecting the orbicularis oculi muscle. So, the orbicularis oculi muscle is a sphincter-like muscle. It's a strap muscle, origins from here, goes all around, and then decussets and inserts again on the medial cancel tendon. You're targeting the lateral part of the orbital orbicularis. Now in this picture you can see that the crow's feet abruptly end here, while here you can see that they are radiating beyond the orbital rim. So you have to increase the amount of dosage, but if you ask me, these are the fixed 3 spots which usually beginners begin with to inject the crow's feet. You have to inject beyond the orbital rim, but as you become more and more confident, you can experiment with that as well. But if you get crow's feet beyond this, then you have to target the orbicularis muscle beyond that as well. You should try and be above the zygomatic arch, because once you go beneath the zygomatic arch, you are dealing with the muscles of the face, and sometimes inadvertently you can cause asymmetric droop of that side of the face. This is again a photo depicting. This is a before and after of a patient where we can see that crow's feet injection has caused softening of these lines. The aim is to soften these lines and not completely make them vanish. Now there are certain consensus recommendations. You can get this paper. It's a paper published in PRS in 2004. Now recently, even the Indian group has come up with consensus guidelines for Indian patients. But usually a starting dose of 12 units, 12 to 20 units is more than enough. Each side can be injected, and the number of injection spots can vary between 2 to 5. Now I'm going to show a quick video of how we inject the lateral orbicularis. So I prefer to use a tuberculin syringe with 26 gauge needle. After loading, I change the needle to a 30 gauge needle. And although people say that for beginners, it is good to keep the direction of the needle away from the orbital rim so that you don't inadvertently enter into the orbit and cause diplopia, because sometimes it can diffuse into the lateral rectus muscle. But if you keep a finger within the orbital rim, you don't cause that complication. And this is how you inject in the crow's feet area. It's subdermal injection. You raise a bleb, and approximately 3 to 4 units at each point is more than enough in the crow's feet region. Now this video also shows how to inject the forehead muscle, the eyebrow muscle, but I'll just come to that later after I discuss. Oh, sorry. Okay, so now this is what we were talking about, the component of a wrinkle. So this is because of aging that you see these static rhytides. Even when the patient smiles or relaxes, you see these rhytides. So these cannot be treated with Botox. So you need to perform a surgical lift for these patients. Now coming to the next indication, which is very commonly asked by patients, even in ophthalmology, is the forehead muscles. Now, forehead muscles is basically a complex interplay between the eyebrow muscles and the forehead muscles. Basically, you have to consider injecting both together. Some people plan sequential injections. First they inject the eyebrows, then the forehead, or vice versa. But usually for beginners in the forehead, you should try and inject above, keep a distance of approximately 2 finger breadths, and then inject above, because if you inject lower down, you're going to cause paradoxical eyebrow drooping, which doesn't look good, especially in female patients. There are various patterns which are followed, but each pattern should be customized to the patient because the anatomy of the frontalis muscle is different in different people. And usually a starting dose, I'm more conservative. The consensus guidelines say around 15 to 20, 30 units, but I usually start with 8 to 10 units in the forehead for a female patient, and maybe 12 to 15 for a male patient. There is a newer technique where we dilute the Botox from 4 units to 0.1 ml to 1 unit per 0.1 ml. It is called as watercolor or micro droplet Botox, where you can get a smooth pattern on the forehead without causing too much freezing of the movements. This is a patient I've injected higher up in the forehead to get a good balanced result. Now, as I was discussing, the eyebrow muscles are a complex interplay with the forehead muscles. For the eyebrow muscles, basically we are targeting the corrugators and the corrugator muscle and the procerus muscle, which lies here. And the lateral part of the eyebrow is basically controlled by the orbicularis muscle. So once you relax the orbicularis, you get a lift of the lateral part of the eyebrow, which is basically desired by a lot of female patients. This is how you inject the central eyebrow, usually approximately 4 units in the procerus and the belly of the corrugator, and then maybe 2 to 3 units in the tail of the corrugator. Again, the consensus guidelines depict the same. This is a before and after result. Now this patient would require 2 stages of cosmetic rehabilitation. One is to soften the corrugators by injecting Botox, which we have achieved, and after this, if you see, these are static RITDs now. These would require filler injection with utmost caution because it's a danger area of the face. Botox can also be used to augment surgical results. So if you have a patient with eyebrow droop along with dermatochalasis, you can perform a blepharoplasty before, and after blepharoplasty you can augment the results of your blepharoplasty by just elevating the eyebrow to get that magic effect for the patient, and you see how relaxed the eyebrows look now, and even the blepharoplasty results look more augmented if you use a Botox. You can also adjust the tarsal platform show or any asymmetry of the eyelid fold with Botox by injecting the eyebrow or the forehead muscle and adjusting. Now, last but not the least, some people complain that their eyes become very narrow while smiling. This is because of a hyperactive or pre-tarsal and preseptal orbicularis in the lower eyelid. If you use 1 or 2 units of Botox in this eyebrow roll, you can see how you can get a very good result and the eyes look more open when they are smiling. Last but not the least, everyone says that Botox causes ptosis. So ptosis is known to be a side effect of Botox, but nowadays we can even treat a mild amount of ptosis by injecting Botox. If you look at this diagram, the orbicularis is basically a constrictor of the eyelid, while the LPS is a protractor. So when we are injecting Botox for ptosis, we inject in the pretarsal orbicularis in a guarded manner at particular 2 points, so that the orbicularis relaxes and the LPS acts unopposed. So it gives you a lift of approximately 1 to 2 millimeters. Lot of times we experience that patients, after injection of the eyebrow and not covering the lateral part of the frontalis in the forehead, experience something called as the Spock phenomena, in which there is an unopposed action of the lateral frontalis, which gives a very quizzical appearance to the patient. This has to be corrected by injecting just a single spot, maybe 1 or 2 units in the lateral frontalis muscle to cause eyebrow depression. I would like to end by saying that when we are injecting Botox, the summary of the injection has to be that you don't cause the patient to look same in whatever way he expresses. So you maintain the expression of the patient so that when they are emoting, they can emote properly. Otherwise, you're going to cause a lot of marital discord after Botox injection. So maintain the patient's natural appearance, but soften it a little bit. To summarize, you have to understand the anatomy properly, be conservative, especially if you're injecting initially, make the patient comfortable. Most important is maintain pre and post injection pictures and records of the patient, and combination therapies, which Debraj is going to speak about, are the way to go because you cannot just achieve everything with just one procedure. Thank you.
Thank you, Dr. Adit. That was really a crisp presentation and which must have enlightened everyone in the audience.